Bismillahirrahmanirrahim. The next topic in nephrotic syndrome is minimal change disease. Minimal change disease mostly affects the children between age 2 to 6 years, but it can also affect the adults sometimes. The disease is often associated with other diseases such as Hodgkin's lymphoma and atopic or allergic conditions such as allergic rhinitis or eczema. The disease may also follow respiratory tract infections or prophylactic immunizations. The pathogenesis of minimal change disease is poorly understood, whereas the most widely accepted pathogenesis includes immune dysfunction, which affects the T cells. So the T cells release cytokines damaging the food processes of podocytes. So let's say this is the food process of a podocyte. Normally it is negatively charged, whereas albumin protein is also negatively charged. So normally these two negative charges repel each other, inhibiting the loss of protein from the urine. So in this case, there is a loss of the food process resulting in neutralization of the charge. So more albumin is excreted through these podocytes into the urinary space and resulting in proteinuria. The immune dysfunction could be due to any reason, such as in Hodgkin lymphoma, where T cell abnormalities are well understood, and certain other conditions such as atopy, or also commonly known as allergic conditions, such as rhinitis and eczema. So the proteinuria in minimal change disease is greater than 3.5 grams per day. The histological picture reveals effacement of the food process of the podocytes, giving it a more flattened appearance. The classical diagnostic feature of minimal change disease is the flattened podocytes with no glomerular damage. As you can see here, there is no glomerular damage here. The glomeruli look absolutely normal. There are no inflammatory cells, and moreover, there are no immune complex depositions on electron microscopy. Another feature of minimal change disease is that the proximal tubular cells may contain excessive lipids and proteins, which reflect tubular reabsorption of proteins and lipids from the renal tubules. Hence the name lipoid nephrosis is also used to indicate minimal change disease. The disease typically presents in 2 to 6 years of age, but it can also affect adults. The signs and symptoms are of nephrotic syndrome, which includes proteinuria. One thing you need to remember is that the proteinuria in minimal change disease is highly selective, which means it allows only smaller proteins to be excreted in the urine, such as albumin. Moreover, there is no hypertension or hematuria. The disease is often associated with the Hodgkin's lymphoma or allergic conditions, as we discussed earlier. The definite diagnosis is on the histological study of the biopsy. The minimal change disease has an excellent prognosis and resolves at puberty. Moreover, it has an excellent response to the steroids. If the disease does not resolve at the puberty, even in that case, the response to the steroids is exceptional. So a 5-year-old child presents in the clinic with generalized swelling. Urine analysis revealed proteinuria 3.9 grams per day, which is of the nephrotic range. Provisional diagnosis of minimal change disease is made. How will you confirm the diagnosis? The diagnosis is confirmed on the histological studies of the biopsy. What is the differentiating point on the histology? The differentiating point on the histology is that there are flattened podocytes with the effacement of food process, and there is no glomerular damage. So what kind of proteinuria is occurring in the minimal change disease? The proteinuria in minimal change disease is highly selective. And why is it highly selective? It is highly selective because the proteinuria is due to the loss of negative charge of the food processes of the podocytes, resulting in an increased excretion of albumin. Another thing that you need to remember is what differentiates the post-streptococcal glomerulonephritis from the minimal change disease, since both of these diseases are common in children. So one thing is that the minimal change disease is a nephrotic syndrome, whereas post-streptococcal glomerulonephritis is a nephritic syndrome. The proteinuria is supposed to be more than 3.5 grams per day in minimal change disease and less than 3.5 grams per day in PSGN. Moreover, there are complaints of hematuria and oliguria in PSGN. The edema is generalized in minimal change disease, and periorbital edema, which is localized edema, is more common in post-streptococcal glomerulonephritis. So that brings us to the end of discussion. If you have any questions, do let us know in the comment section. Thank you.